My objectives today are going to be to describe the traditional roles of a critical care pharmacist, and then next to give examples of a critical care pharmacist performing research and also quality improvement. So when I think about the traditional roles of a critical care pharmacist, I think about making rounds every day as a part of an interprofessional team. I think about performing medication reconciliation and making sure that medications are restarted, that the patient needs to have continued, to make sure that perform appropriate pharmacokinetic monitoring to assess medications such as maybe vancomycin. I think about stewardship activities, so recommending to stop inappropriate antibiotics, making sure everything's dosed appropriately, the patient doesn't have any drug allergies, looking for adverse drug events, also giving information, education to nurses and physicians, also optimizing nutrition along with the dietitian, and then I also think about responding to resuscitation events as well. But what many of you in the audience might not think about is that, believe it or not, there is data showing that a critical care pharmacist has a big role in quality improvement research and scholarship. The use of a pharmacist has been shown to decrease medication costs, to also decrease adverse drug events, to improve infectious disease outcomes, to also to contribute to better thromboembolic and infarction outcomes, to promote appropriate use of stress ulcer prophylaxis, and to enhance the appropriate utilization of different protocols. So what my goal today is to give you some specific examples of some of the research I have been involved in as a part of an interprofessional team at Vanderbilt to really just show you what a pharmacist can do. So first, I'm going to show you some of the work that I've done specifically with regards to spontaneous awakening and breathing trials. So those of you that are not familiar with spontaneous awakening trials and spontaneous breathing trials, the process that we use at Vanderbilt is the night shift nurse, whose shift runs from 7 p.m. to 7 a.m., will assess the patient and determine whether or not it is appropriate to turn off the patient's sedation and analgesia. So in other words, they'll make sure that their FiO2 is not greater than 70%, they'll make sure they're not chemically paralyzed, they'll make sure that they're not on a continuous infusion of a sedative for a refractory seizure disorder or alcohol withdrawal. And if there is not a contraindication, then they will pass this off to the day shift nurse, who will come in at 7 a.m. And once the day shift nurse gets settled, then they will turn off the sedation and analgesia. And they will leave it off unless the patient would become agitated or anxious or have some pain. And they would first try to give a dose of intermittent fentanyl, but if that wasn't successful, then they would start the sedation or the analgesia back at half the rate. In the meantime, the respiratory therapist would be assessing the patient to determine if it was appropriate to do a spontaneous breathing trial. So in other words, they make sure they weren't on vasopressors, that their FiO2 was less or 50% or less. They'd make sure they weren't having low O2 sats, that they weren't tachypnic. And if none of these contraindications were there, then what they would do is put them on a spontaneous breathing trial. And assuming the patient didn't drop their O2 sats, they didn't become tachypnic, they would leave them on this for either from half an hour to 2 hours, and then the clinical team would come by and extubate the patient if appropriate. So as you learned this morning, if you were in the lecture given by Wes Ely, as you recall, the ABC study was a prospective, randomized, double-blind, multi-center study that was published in Lancet in 2008 that looked at 336 adult ICU patients in 4 different tertiary care centers. So patients were either randomized to an SAT coordinated with an SBT or just an SBT alone. And as you can see here, patients that had the combined SAT and SBT had a 14% reduction in 1-year mortality. They also spent 3 fewer days in the vent, 4 days fewer in the ICU as well. And the number needed to treat was only 7 patients. So we as allied healthcare practitioners can have a major impact just by turning off patient sedation and analgesia and doing spontaneous breathing trials when appropriate every day. So even though this study was coordinated by Vanderbilt, believe it or not, when I arrived there 7 years ago, this really wasn't happening. And it wasn't that we didn't want it to happen, it was that there wasn't someone there to champion it that was there every single day. Our nurses were quite often going to nurse practitioner school, or they were going to nurse anesthesia school, and honestly it took me 1 year of working there before I worked with all 20 different attendings in the MICU. So I stepped up and took this role on since it was logical for me to do this because I'm there every single day. So this was essentially a PharmD-led quality improvement project that I essentially made sure on rounds we talked about the SAT and SBT every day, and then I made sure that this was done and documented appropriately, and then I provided weekly staff performance reports. So we compared data from 500 patients before the quality improvement started and compared this to 580 patients after the quality improvement project was started. So I'll show you these graphs, and if you look at the far left-hand side, as you can see, the SAT safety screen rate of improvement went from 15% to 97% after the quality improvement project was started. The number of SAT safety screens that were passed went from 56% to 79% following the quality improvement project. The next graph, if you look at this, on the left-hand side, this was looking at SAT performance and pass rates. So the gray bar indicates SAT performance. And comparing the left to the right, you may be like, oh my goodness, what happened? You actually did less SATs. But this is not true. What you're going to see in the next slide that I'm going to show you is we had so many few patients more sedated because we were turning this all off that, yeah, we did less because no one was on sedation. So this was actually a very good thing. And as you can see, our rate of SAT passage also went up from 55 to 66%. So as promised here, you can see that we had far fewer patients that were on continuous infusions, and you can see that the number of patients that were on intermittent doses of fentanyl or nothing also improved. And this was all secondary to this quality improvement project. So I hope this highlights for you what a major role that a pharmacist can have with regards to conduction of the spontaneous awakening trials and spontaneous breathing trials every day as a part of the A through F bundle. So if you were at the plenary session yesterday or the talk this morning given by Wesley Lee, then you've learned a lot about the A through F bundle. So I want to further emphasize specifically what the role the pharmacist has with regards to this bundle. So this is a study that he presented showing that the implementation of this bundle, what the outcomes were when we implemented this in 15,000 adults. But what I want to highlight are there are 3 pharmacist authors of this. And so just to review this study, this was a prospective multi-center cohort study from a national quality improvement project. We did this in 68 adult hospitals. And so essentially what we were looking for were the outcomes from both total bundle compliance or partial bundle compliance. So specifically what my role within this was I served on the executive committee of this. So the U.S. was divided into 3 different regions. There was a western region, a central region, and an eastern region. So as a member of the East Coast team, then all of the different teachers, so there were physicians, nurses, pharmacists, respiratory therapists, we all went and we taught all these different individuals from these hospitals at a 2-day course and made sure they understood the bundle. And these individuals had to they had to have a nurse, and they could bring either a pharmacist and a physician as well. And so essentially, and these different hospitals that signed up to be part of this collaborative had to have buy-in from management. They actually had to have a signed paper from the management to say that, of their hospital, to say that they would support this. But my role was not only to provide education to these individuals, but every month we had phone calls with them. I went on site to 3 different hospitals in North Carolina and rounded with them to make sure they understood how to implement this. And then I also, there was a listserv that we got asked multiple questions with regards to implementation of this, and regularly answering questions on the listserv were my roles within this project. And as you recall this morning, implementation of this bundle resulted in decreased mortality, decreased incidence of next day ventilation, decreased incidence of coma, decreased incidence of delirium, decreased use of physical restraints, decreased ICU readmission, and also the decreased discharge to a facility. And this was all dose dependent. So in other words, the more of this you did, the more of this that you decrease all of these different outcomes. So I hope this shows what a huge role that a pharmacist can have with regards to their role in the A through F bundle. So the next part that I want to discuss with you is a pharmacist's role in a post-ICU clinic. So for those of you who are not familiar with PICS, or post-intensive care syndrome, this is essentially when patients that have sequelae of critical illness. So they may have cognitive impairment. They may have also mental impairment where they're anxious or depressed or have post-traumatic stress disorder. And they also may have physical impairment. So in other words, they can't walk as far, and they also may have lung dysfunction. following critical illness. This still occurs in young patients and also those without comorbidities. And PICS clinics are one means that we think are ways to treat this, and we have a clinic at Vanderbilt that specializes in this. So we decided that we wanted to quantify all the pharmacy interventions that I made at our ICU Recovery Center at Vanderbilt. So my role is to perform a very comprehensive medication review at this clinic. So in other words, I interview the patient, make sure every medication has an indication, looking for adverse drug events, making sure they're appropriately immunized, make sure everything's cost effective. So this is a graph representing all the meds that were discontinued at the ICU Recovery Clinic. As you can see, we stopped antifungals, we stopped one antiplatelet agent, we stopped antipsychotics, which were continued following the ICU. We stopped insulin, we stopped a leukotriene receptor antagonist in a patient that was having nightmares. We also stopped laxatives, sodium bicarbonate, sedatives, vitamins and minerals. We stopped antibiotics that no longer had indications, bronchodilators, H2 blockers, and proton pump inhibitors, which I'm sure were stress ulcer prophylaxis from the ICU, and also steroids that were no longer indicated. We also started medication. So we started antibiotics. This was a specific patient that had Clostridium difficile who was actually not taking his flagyl or his metronidazole because of the metallic taste. And this patient had been a long-term patient in the ICU, so we switched his antibiotic. We started an anticholinergic, an antidepressant, an antidiarrheal, diuretic. We started neuropathic pain meds to decrease the use of opiates. We started a proton pump inhibitor, a statin, steroids, vitamins, some meds for constipation in people that were on opiates, and H1 blockers, some non-steroidal agents, and then a few H2 blockers. We also made numerous interventions with regards to adverse drug events, so implementing preventive measures and also treating them. If you look at the yellow, these are the adverse drug event preventive measures that we implemented. So we implemented measures against constipation, also diarrhea, also hypoglycemia, nausea, osteoporosis, overdose, oversedation, photosensitivity, thrombosis, and also thrush. There were numerous patients that we saw that were on inhaled steroids that were not washing out their mouth. And then we also treated adverse drug events such as constipation, emesis, fatigue, hallucinations, hypoglycemia, insomnia, nausea, peripheral edema from amlodipine, oversedation, and thrush. Other things that we did, as you can see, we increased doses in 9 patients, decreased doses in 2 patients. We supplied a pill box to increase compliance in 8 patients. As you can see, we administered numerous influenza vaccines, and this was a lot of patients that had been admitted with influenza, but unfortunately they were failed to receive vaccinations before they were discharged. And also we administered pneumococcal vaccines as well. We also performed laboratory testing in 5 patients as well. So this really, I hope this emphasizes what a role a critical care pharmacist can have not only on an inpatient basis, but also on an outpatient basis as well with regards to optimizing medications. The last thing that we will specifically look at with regards to interventions a pharmacist can make is specifically looking at resuscitation fluids. So I'm going to tell you this because I'm very humbled, and honestly it was something that wasn't even on my bucket list to happen, but happened to me within the last year. I was fortunate enough not to only be on one, but I was actually on 2 New England Journal of Medicine papers. And so I'm telling you this because I want to emphasize that a pharmacist can not only be involved in research, but they can really be involved in high quality research. So the first of these is what Wes Ely has already presented on a couple times, which is the Mind USA study. So that was the study that looked at haloperidol versus ziprasidone versus placebo for the treatment of delirium. So my role as the person that's always in the ICU was to ensure compliance with this protocol every single day. And when people were concerned with patients having adverse drug events, to also be the one to calm them down and to encourage compliance with the study. My role with the second study was a study called the SMART study, looking specifically at resuscitation fluids. So this study was published in the New England Journal this past March, and Just to give you a little bit of history, comparing balanced fluids to saline. So it's thought that normal saline, due to its chloride load, can have detrimental effects on your kidneys, as compared to balanced fluids, which are buffered with lactate and acetate instead. These are thought to be more helpful to your kidneys. So this study was a pragmatic cluster randomized multiple crossover trial in 15,000 adults in the ICU, and patients were randomized to either receive balanced crystalloids or normal saline. So this shows the randomization. As you can see, a lot more patients were included from the medical ICU as compared to the other ICUs. We started it in the medical ICU first because both the primary author and senior author, that's where they work. So my role, once again, within this study was to make sure that patients receive the right resuscitation fluids every day. So on rounds, when I saw that the patient was receiving the wrong resuscitation fluid, to have the team change this. And then also, I would receive a phone call or a page from the primary author of this study if the nurse had documented that they gave the fluid that was not the study fluid that month. And my role, once again, was to interact with the nurse and to find out if they actually did give the wrong fluid or if it was documented incorrectly. And then what we found early on in this study was that, in fact, the resident or the physician would contact the nurse and say, hey, we need to give a liter of fluid, but they wouldn't always say which fluid to give. And so the nurses were pulling fluids out of our automated dispensing cabinet, and it wasn't necessarily the right fluid based off our protocol for that month. So I also had to make signs to put them on the automated dispensing cabinet every month to make sure the nurses knew which fluid that the patients were supposed to be receiving. So as you can see here, we changed every other month in the different ICUs with regards to what fluids that they were receiving. My last role within this study was to serve as a champion for this with regards to the other units and help locate which individuals within that unit would be advocates for the study and to make sure that they also will be compliant with the study as well. So as you can see here, the balanced crystalloid group did receive more balanced fluids, and the normal saline group did receive more normal saline. And as not all that surprisingly, looking at the chloride concentration, the balanced crystalloid group obviously had a lower chloride and had a higher bicarbonate concentration. With regards to the primary outcome was MAKE 30, which is major adverse kidney events at 30 days. So this was a composite outcome of persistent renal dysfunction, death, and new renal replacement therapy. And as you can see, this is 1% lower in patients that receive balanced fluids. And you may be thinking, this is 1%, that's not a big deal. But you have to consider that 5 million people receive resuscitation fluids every year. So that's 1% means a lot. So this really helps show that balanced fluids are the resuscitation fluid of choice. And I hope this has really indicated to you what a huge role a pharmacist can have in a major study with regards to ensuring appropriate utilization of the protocol. So in conclusion, a critical care pharmacist has an invaluable role in patient care in the ICU. A critical care pharmacist is also an essential member of a critical care research collaborative team due to their unique skills and consistent presence in the ICU. So I hope as many of you are designing multi-center randomized studies that you will consider having a critical care pharmacist as a part of your research team. Thank you. Thank you for the invitation to speak here, and any questions I'm happy to take at the end of everyone's presentations.